So of course I want to start out with some kind of humor, and the only robot joke I could find is, what do you get when you cross a robot with a tractor? And it's a transformer, for anyone who wants to know that, okay? So we're going to talk about advances in robotic surgery, knee surgery in particular, and knee replacements in very particular. And what I was planning on doing is just briefly touching on why we do knee replacements, and then take you through sort of the history of what we've gone through, starting out with no technology, and then kind of the gradual implementation, sort of incrementally, of technology, which has left or allowed us to arrive where we are today, on the verge of doing robotic knee replacements, total knee replacements. We've actually been doing robotic partial knee replacements for a couple of years, and this has sort of evolved into a much more sophisticated procedure. So I'm going to sort of go through some of the history of that. So just a little bit about myself. Dr. Oliver already touched on. I was undergrad at Boston College, went to Tufts Medical School, a couple years of general surgery out in Chicago at Loyola, came back to New England Medical Center, finished up my orthopedic residency there, and then did a sports fellowship with Lyle McKaylee at the New England Baptist and Children's Hospital. I'm currently practicing on here for 26 years now. I can't believe it's been that long. And hopefully another 26 more after this. And I've been fortunate enough to work with U.S. figure skating over the last 18 or 19 years, and was lucky enough to be selected to be the team physician for the 2010 Winter Olympics for that team. So before we get into things, I just want to give a little background about knee anatomy for those of you who don't know. So the knee we think of as having three joints in one. There's the bones, the upper bone, the femur, lower bone, the tibia, the fibula on the side, and the patella here. And the three areas we think about are the inner side or medial side of the knee, the outer side or lateral side of the knee, and the patellofemoral joint area. There's major structures around the knee. The articular cartilage, which you're very concerned with, that's what covers the ends of the bone, provides that nice smooth surface, more slippery than an ice skate on ice. And I know that very well. Anyway, and the other supporting structures, the ligaments, there's four main ligaments around the knee, the collateral ligaments on either side, and the cruciate ligaments in the middle, and you can ask Tom Brady about those. And then of course the patella tendon in front, that allows you to extend your knee. And the thing we deal with a lot in sports medicine, the meniscus or the cartilage, these C-shaped rims of tissue on either side. That's just a little background. So osteoarthritis. That's probably the most common arthritis we see. It's a degenerative disease where that articular cartilage wears out. Affects 15 million plus Americans. 46% of people will develop it over their lifetime. The older you get, the more you tend to get it. Just a few facts, 350 million people worldwide, 40 million men and women. This is something that is selective. It's not an equal opportunity disease. It does affect women. More than men, 60% of arthritis occurs in women, can cause variable degrees of disability, and most people over the age of 60 do have some degree of arthritis. And as the baby boomers get older, we're going to see those numbers go up even higher. It certainly affects people in a lot of different ways, not only physically, but mentally, and it's a huge cost to the economy on a yearly basis. Again, just to go over how this is an age-dependent thing, and a lot of this is activities. So certainly the older you are, the more activities or at risk you do, and you can see that reflected in these charts. Weight is a huge factor, and something I learned that I try to tell my patients, you think if you lose a pound, it's a pound less on your knee, but it isn't. 1 pound loss is 4 pounds less on your knee, and that's because of the way the lever arms work and your muscles work. So even a modest amount of weight loss can have a big effect on your symptoms. And if you think about it, you know, when everyone's wearing their watches and stuff that tracks their steps and all, you know, people probably take several thousand steps a day, but even at 1,000 steps a day, if you lose 10 pounds, that's 10,000 pounds a day your knee sees less of. So that's got to have an effect going forward over a long period of time. This kind of talks about the causes of disability. It's a huge effect on the economy. Arthritis, rheumatism, the major cause of disability. Spine problems, the second. So if you take Dr. Leckie and the rest of us, we got things pretty much covered here, I think, in the disability field. Types of arthritis you run into, osteoarthritis, by far the vast majority of arthritis. That's the wear and tear stuff. That's the tires going bald on the car, if you know what I mean. Other types of arthritis, inflammatory arthritis such as rheumatoid arthritis, 2.1 million. Other things you may have heard about, gout or pseudo-gout, and some of these other inflammatory conditions, a little less common. So what does it look like? This is a couple of x-rays. The knee on the left is a normal knee. What we look for is these spaces between the bones. Hope you can see it pretty well up there. The space shows up in the bones because the cartilage doesn't show up on x-ray. The x-rays go right through cartilage. But as that cartilage wears away, the bones start getting closer and closer till you get a situation like this over here where the bones get real close. And sometimes they'll be touching where you see what we call bone on bone, and that's a sign of very severe advanced arthritis. So how do you treat it? We all know, we tell everyone rest, ice, elevation, heat, medications, weight loss we talked about. Physical therapy can be very helpful. Sometimes we'll do cortisone shots, or there's a type of injection of lubricating shots, like putting oil on a squeaky hinge, basically. Sometimes for early arthritis, we can clean it up with arthroscopy, and then if all that fails, then we'll start talking about joint replacements, knee replacements, which is sort of the subject of my talk here today, I guess. So a nice segue into that. Oh, yeah, happy pills too. You can't forget those. So anyway, we're going to talk about joint replacements. So this is projected for 2017, 705,000 knee replacements in the U.S. projected this year. These are primary. The ones in are yellow are primary knee replacements. That means someone who has not had a knee replacement before. So that's a full knee replacement. A smaller amount with partial knee replacements. So sometimes if someone's only worn out the inner side of the knee, we can just replace that side. And this other number is for someone who's had a knee replacement already, and now that's getting toward the end of their lifespan, and they need to have a second knee replacement, or in some cases even a third, and that would be what we call the revision knee replacements, and those numbers account for that. Interestingly, these numbers keep going up. That's a big number, but you can see by 2030, the knee replacement number is estimated to go up 673%, which is huge. So if you want to invest in something, too bad, I don't know how to do it, but that'd be a good investment, I guess, pretty safe. The partial knee replacements, only 8% of knee replacements are currently partial knee replacements. It's felt to be probably an underserved area, but something that probably will get more popular as time goes on. So I'm just going to kind of walk you through a little bit of the history of knee replacements. Started back in the 1950s. There really wasn't much of a plan. What we used to do then is take an x-ray. Not I did. I wasn't around in the 50s. Anyway, but we take an x-ray and put it on an x-ray view box, for those of you who remember those things, and hold up what looked like a drawing of what a knee replacement was. And they'd have different sizes. We'd hold it up and kind of get the best guesstimate of what would fit the best. It was not an exact science by any means whatsoever. And we would secure those knee replacements in with a bone cement. That's pretty much what happened until the 1990s, when we started doing what's called navigated knee replacements. And I'll get into that in a little bit. That's where we started bringing computer technology, what we call computer navigated systems, into place. They started putting the navigation on the tools, which was okay, never really took off as much. And now the next iteration is this robotic surgery, which we'll get into again in a minute. So that kind of gives you an overview. So knee replacements, what do we do? The big issue with knee replacements is cutting the bone so we can fit the prosthesis on the end of the bone. And really, there's 6 cuts we have to make. That's what takes a knee replacement. If you resurface the kneecap or the patella, it's one more, it's 7 cuts. And these are the cuts. And I just bring this up because this will come in a little handier down the road here. So we have to make a square cut off the end of the femur, and then we'll cut sort of a little of the front, a little of the back, and then we make these angle cuts called chamfer cuts. And that femoral component is going to cap off the end of that bone there. And then on the tibia, it's just a straight cut right across here. The significance of this is the prosthesis, the femoral prosthesis of tibia, they come in 8 different sizes. So it's not like you can make the same cut on everyone. So you have to sort of fit the prosthesis for the person's size. So you have to try to customize it to some extent. However, you're only limited to these 8 sizes, and And the idea of getting these cuts right for each different size was rather daunting, which sort of led to a lot of the technology we're talking about today. So in the past, what we would do is use these, what they call them, jigs. They were cutting guides. And there was a process of putting them on and measuring and make sure you had them right. And the thing is that some of these, you'd put one piece in and you have to use a second or a third piece, kind of build something almost like building blocks. And it was that third piece or so that would you use to make the cut. And every time you do something, you introduce a little bit of error, basically on every step. So that's where things sort of fell apart a little bit with this technique. The error rate is high as far as getting the proper alignment. And here's just an example of that. This is the jigs in real time, what we would use on a femur, starting from sort of left to right. So first, we put a rod down the femur to establish a kind of a fixed point. And then we put this little jig over the rod, and then this thing here fits onto this jig. And then we put pins in this, so we end up with this, and then we make this cut through this. This is now the third piece we've assembled, because now we got to take all these things out because we can't cut through the bone with a rod and stuff in it. And then after that, we've made that end cut. Now we have to make 4 more cuts with this contraption here. And we take all this stuff on, we pin this on, we got to make sure we get the rotation just right, but we're kind of eyeballing it because that's the only thing we have available there. So we make the cuts with that, and most of the time we get it right, but there is kind of, to some extent, hoping we get it right. Introduced navigation. The navigation was one of the big breakthroughs in knee replacements for alignment and putting these things in the proper position. What it did, this navigation unit here, it's a computer basically with basically a mini GPS unit. Anyone have a Wii system here at home, or one of those kind of where you can wave your hands in front of your TV and you can play games and you don't have to have a console sometimes? That's a digital camera, and what it does is it tracks what we call little trackers. We will put these trackers into the bone on the femoral side and on the tibial side, and then the computer will ask us to point out certain landmarks. The surface of the bone, the front of the bone, the back of the bone, the sides, and basically we'll generate a 3-dimensional picture in the computer of the knee. And then in that we can place these components, and the accuracy of the cuts and the angles and stuff are within like 1 to 2 degrees. Normally, if you were to eyeball something, you could be 5 degrees or more off and not even realize it. So this greatly improved the accuracy of how we do these knee replacements. So this shows Dr. Oliver in the OR doing a nav knee. And what he's doing here, he's got the knee in his hand, he's moving it around. He's watching the screen, and in real time as he's moving the knee is actually moving on the screen. And it's pretty highly accurate, and it really allows us to decide how much bone to take off, and it helps us to size the proper size of the prosthesis to go on both the femur and the tibia. It was a real breakthrough, and sort of the first big breakthrough as far as positioning and all for the knee replacements. So it's more accurate. Because of that, we can use smaller incisions because we're relying on the computer to tell us things rather than having to visually look at them and put these big cutting blocks in. We end up with better alignment of the joint, and that theoretically leads to improved outcome. So nav, and then they say, well, what more than that? We're still limited by nav because we still have to do everything real time. We can't sort of plan ahead. Everything, all the planning is kind of done at the time of surgery. So a company called Stryker came out with the Mako robot. And this is the robot here. It doesn't look like a robot. It doesn't look like Robbie the robot or whatever. No head, no legs. This is a one-armed robot. And there's a computer in here. It's linked to this computer here. You can see there's that camera, again, that digital camera that tracks. And what we do is the same sort of thing with the nav. We put these trackers on the bones, and the computer is going to ask us to point out different landmarks. Now, prior to surgery, what we do is we get a CAT scan of that knee, and this computer can actually correlate the marks we point out with that CAT scan, and it will make a 3-dimensional model using that CAT scan, and again, it's highly accurate. So this is what we would see on the screen here. This is actually the CAT scan. So before we've even started the surgery, we've got representations of the prosthesis here we actually position them in the patient. We can size the patient. We can figure out what we want to do for alignment before we've actually even made a cut. So this took it to a whole new level as far as precision, accuracy, something like we've never seen before. And this is sort of the state of, this is actually used for a partial knee replacement. As you can see, we're only replacing one side of the joint here. We have been doing this for a couple of years, and the results have been very good. This is, again, what we do is the computer here is asking us to point out different areas on the knee. This is that CAT scan. It's a three-dimensional view of that CAT scan. So it asks us with a pointer, which he is using here, surgeon, he's pointing out all these things. Now, we've already made the plan of what we're going to do. And once we've got the computer sort of set up, we can position that prosthesis in the knee. It's actually not in there, but it's virtually in there. We can put the knee through a range of motion. We can test the ligament tightness or looseness, and we can adjust these prostheses based on what we're seeing in real time as far as ligament tightness, any kind of rotational issues, and that sort of thing. And then once we've got it all locked in, then we bring the robot arm in, and on that, in this particular thing when we do the partial knee replacement, there's a high-speed burr on the end of that robot arm, and it will remove bone just where we've planned to remove it. That robot won't let you kind of color outside the lines, if you will. It's almost like these new cars, when you're driving down the road, if you swerve off and you're starting to get outside your lane, it will automatically pull you back into your lane. That's kind of what this robot does when we're making our cuts here. There's this shows the prosthesis in the patient once it's done. This is an x-ray of what it looks like. You can see it's just on the one side, the inner side. There's a space between the metal here because there's a piece of plastic in there, and just like cartilage, that doesn't show up on x-ray. So you can see it from front to back and from the side here. And I'll almost tell you, in my experience, what you plan on in the computer almost always looks like that on the x-ray. This is just a short video of kind of how this works. So this shows the robot with the arm. And I'll just kind of narrate as this goes. So it shows the robot here, and these are the computer and the camera there. Now this shows the robot moving around. It actually doesn't do that. The surgeon actually moves that. That robot, if you don't touch it, will just stay there. It's not powered in any way. All it's designed to do is limit where you can go with it. You kind of define the coloring book lines, and it lets you color inside those lines, but really nothing else. So this was set up mainly for just a partial knee replacement. And you can do it on the outside or inside. You can do it under the kneecap. So you can just, if someone just has arthritis in their kneecap, they can do that. This is showing it on the outer side of the knee or the lateral side of the knee. So these are all the components that come with it. So it looks pretty basic, but the technology to make it simple is truly astounding. It'll show it a little bit better here. So here, you can move on through. It's going to show basically arthritis, kind of what we talked about. Sorry if this is a little redundant. Unfortunately, I tried to shorten this, but it has to go through its whole thing. But it's not a very long video. This is the CAT scan that we get preoperatively, and what it does, it assembles it into basically a virtual knee that resides in the computer that you pull up on your screen. It allows for you to adjust the ligament tensioning, the rotation. You can see as you move the knee on screen, it moves real time with you. This shows the ligament tightness or looseness, and what they're showing here is you can adjust the position of the prosthesis and it will affect your ligament tightness, and this is something you can do real time. So if you've got a really loose knee, you can adjust real time in the OR to tighten those ligaments up just by repositioning that prosthesis. And at this point, you haven't made any bone cuts at all. And then you bring in that robotic arm. This shows how it works. It just kind of burrs off the bone, and it burrs it off just in the shape of the prosthesis that you're going to put in there. So it just did the tibia, now it's on the femur. And it kind of takes that off, and because the incision is so much smaller, the patient doesn't have as much pain, the recovery is much quicker, and that's how the the prosthesis works. So how does it do? How well does this technology do? It's very new. Not all places have it yet, but this shows the experience. So as far as is it more accurate? Absolutely. It's twice as accurate at least. If you look here, this is either the degrees or the millimeters of how far something is off. The yellow is the standard way using the old guides. The blue is the Mako, and you can see the lower, the better. So in almost all parameters, the Mako is so much better. As far as survival, this measures how well these knees do at 2 years. This is the Mako here. These are the others. This is what they call a revision rate. In other words, how many knees, what percentage had to be redone at 2 years. 0.4% for the Mako knees, up to 5% for the standard way of doing it. So clearly, technology is much better. How are people? How satisfied are they? Twice as satisfied almost with the Mako knee. Just because it's felt that you can get that ligament balance much better and the positioning much better. So that's great. We got the partial knee solved, but we still haven't got it all the way. The next thing is the full total knee. Recently, Stryker acquired Mako, and they embarked on a Herculean task of modifying this so it would do a full knee replacement, and they have succeeded. They've changed the arm from a burr now to using a saw, and the screens are the same. Again, we can do all the preoperative planning ahead of time. We can position the prosthesis ahead of time as far as sizing, rotation, all that position. We can do the balancing as far as the ligaments, and this is showing the relative looseness or tightness of the ligaments on either side. And also helps, and once you've got everything set, you kind of lock everything in and you bring this in and you do the cuts. One of the very interesting things about this is that, coloring in the lines I'd mentioned. In the knee, when you've got a saw in the knee, that can sometimes be a very frightening thing because there's a lot of named structures, especially in the back of the knee. Things like arteries, veins, big things that you don't want to violate. This creates a barrier that saw blade will not go beyond, no matter how hard you try. So if you got major structures back here, you can't see them. It's in the back of the knee. They're embedded in soft tissues. You're looking at the front of the knee. You don't know, how deep that blade is going when you're doing your surgery sometimes. And this takes that worry right out of it. So I do have a little video here. This shows in real time, this doc is checking the ligament tightness, and you can see, it's tough to see, but those things are moving on the side there. So he's checking to see how the tightness is, and you can adjust those prostheses up and down to accommodate that. He's checking the ligaments from side to side, and you can see the knee moving real time on the screen as we go in. And notice nothing's been done here. The prostheses are in the computer, but not in actually the patient yet. The second one here, where again, talking about fine-tuning these ligaments, fine-tuning rotation of the component. You can adjust up or down, and in here you may want to change the orientation, flex that prosthesis a little bit more just so it fits better. So we can adjust the fit, again, before we've even done the surgery, something that's virtually unheard of up until this point. Before this, the only time you know if it fit right is when you actually put it on. So this is truly a monumental advance in the ability to pre-plan and help with accuracy. This is going to show actually here at some point. They do adjust this, and there he's adjusting the flexion here just a little bit, and actually we'll change that around. So again, this is all that preoperative planning you can do ahead of time. And this next is the best, the one I think is the most significant. Here they are making the actual bone cuts with that saw. And if you look here, this blue is the saw blade. And as it's taking away bone, it's taking away the green. And when all the green is gone, then you know you finished your cut. So this is what happens actually during the surgery. You can see how that just takes it away. And you can see there's our barriers that we're not going to let that saw blade go beyond. At one point, the surgeon's going to, just for demonstration purposes, try to push beyond that. And you'll see what happens when he tries to go in the back. You'll see this is this will light up as red if he pushes too hard. And it will just prevent you from causing damage to areas. There he goes there. See? And see how it's turning red? It just won't let you go. It's like hitting a wall. This is going to be available actually at our hospital this month. So making the final of those 5 cuts on the femur. And one thing you notice, no jigs. You don't see any of those jigs that were on there. There's no rods going up in the femur. There's no other external things that you have to put in there or pin to the bone. So you can keep the incisions a little bit smaller, less tissue damage. Here he is cutting the tibia now. Same thing. Go back. There's some major arteries and nerves back here, the popliteal nerve, popliteal artery, and it just won't let him go there. So the advantages summary. Efficient and accurate preoperative planning. That is one of the most important parts of this. You can assess the bone cuts, the alignment, ligament balance before even starting the surgery. Much more accurate bone cuts, better fit for the prosthesis, theoretically should lead to a longer life of the prosthesis. No cutting guides required. And because of that, less equipment is required per case. So we don't have to sterilize as many instruments. We could turn over rooms faster. Less work for the CSR people that have to sterilize this. And it leads to better outcomes and patient satisfaction. So anyone have any questions? All right, thank you.